Thank you all for having me. I appreciate it. All right, so I have no financial disclosures. I'll leave that up for a few seconds. So unfortunately, surgical complications are not uncommon. Everyone, regardless of subspecialty, be it general surgery, bariatrics, colorectal, we're all dealing with the potential for perforation, for anastomotic dehiscence and leak. The rates obviously vary between the specific operations that we're performing. And overall, we obviously want to avoid these complications as much as possible. But when they do happen, our goal is to manage these complications effectively while limiting patient morbidity. And so why should we manage these endoscopically? Primarily, a lot of these patients have multiple medical comorbidities, and so it's beneficial to try and limit surgery and anesthesia time as much as possible. Some studies have also shown or suggested that patients with anastomotic dehiscence and leak who are managed endoscopically may benefit from shortened length of stay and lower readmission rates when compared with patients who are managed surgically. And at the end of the day, this is both diagnostic and therapeutic, and so it gives us the opportunity to have a little bit more information about the complication than perhaps an imaging study might. And so my hope today is to kind of add to the goal of showing that endoscopy can provide excellent and safe management of surgical complications. So during my talk today, I'll focus primarily on anastomotic dehiscence and on leak. I'll go through a couple of treatment algorithms that we can use to manage these patients. I'll mention different endoscopic approaches as well, but I'll try to keep that brief as other speakers will go into much more detail about those modalities. And then we'll discuss management strategies for bleeding and fistula complications. And so sometimes, despite our intraoperative endoscopy, our perfusion test, our leak test, things fall apart. And so when that happens, there are several factors that we need to consider when we're approaching an individual patient in treatment. Hemodynamic stability is number one. It's very important and has to be incorporated into any treatment algorithm that you use. Also knowing whether there's an abscess present is important because that obviously requires source control, and that can be obtained either with endovac or with double pigtail internal drainage like we saw just earlier. Also understanding the information about the size or the depth of the defect. If this is something that's small and just mucosal, then a through-the-scope clip might be a great option, but that same through-the-scope clip is not going to be effective for a full thickness or for a larger size defect. And then knowing what equipment is available at your institution. If over-the-scope clips are not stocked, or if you don't even have a therapeutic gastroscope, then that's obviously going to limit what we're able to do for patients. Another key factor is time and understanding when the patient is presenting to you with this complication relative to their surgery. The cutoffs for early and late vary a little bit in the literature, but acute phase is pretty consistently defined as less than 7 days and chronic being greater than 90 days. It's important to know this because patients with acute processes may do better with stenting versus those with chronic defects may require endoluminal clipping or suturing like we just saw. And so understanding their pathology is really important in choosing the right treatment modality. The treatment options include, as we already saw as well, and I'll try and do this quickly, stenting, endoluminal suturing, endovac, double pigtail stent. Oftentimes we have to do a combination of these approaches to take care of a single patient, and so it's helpful to know all of these valuable tools and have them all in your armamentarium to be able to tailor your treatment plan. So when choosing how to manage these patients, there's no standardized treatment algorithm. This algorithm specifically was published in 2023. You'll note that the first step in the decision-making is hemodynamic stability, which I think is completely appropriate. It then goes on to list kind of multiple modalities that kind of overlap across the timeline of disease process, and so they're not strictly applied to one group over another group. And this is consistent with what I was just mentioning about sometimes we have to combine these modalities in order to take care of a patient. Their paper then goes into much more detail about indications for each treatment. You can see that in this table, and this is obviously too much to review in the talk today. But the important thing to note is that the factors that I mentioned earlier about timing, presence of abscess, hemodynamic stability, defect size, all that is incorporated in these recommendations. And so bleeding can happen from a staple line, it can happen from an anastomosis, even from a PEG tube placement. It can be either intraluminal or extraluminal. And so some of the treatment options for intraluminal bleeding include sclerotherapy with injection of diluted epinephrine, cautery with argon plasma coagulation, or clipping with through-the-scope or over-the-scope clips. And so in general, a combination of two hemostatic modalities offers the best results, but there have been success rates of up to about 85% with over-the-scope clips being used to manage postoperative intraluminal bleeding. Fistula are more chronic issues that can also be managed endoscopically using some of the treatment modalities that we've already seen today. I personally took care of an 18-year-old patient, had multiple congenital cardiac defects and reconstructions, congenital abscess of an upper extremity, a Nissen as an infant, chronic PEG tube dependence, had their PEG tube removed in pediatric GI clinic in May of 2023 and developed a GC fistula, gastrocutaneous fistula. And despite being young with a cardiac history, we wanted to try to avoid surgery as much as possible. And so 7 months later, by the time he got into the adult side of things, we performed an endoscopy and closure of the fistula with an over-the-scope clip. And so success rates for closing a fistula with an over-the-scope clip vary in the literature from 52 to 86 or so percent. But this patient was successful. He remains asymptomatic about 4 months out now. And so this is a still shot of the fistula and a view endoscopically, and then that's that over-the-scope clip that's in place afterwards. And so in conclusion, there's 4 principles of leak treatment that we have to kind of keep in mind. Clinical management, these patients need to be resuscitated. They need to be started on antibiotics in an appropriate time frame. Drainage can be done either surgically, endoscopically, or percutaneously. We need to treat associated factors, so that means optimizing nutrition and addressing any distal stenosis or obstruction that may be present and allowing the leak to persist. And then we obviously need to close the defect with any of the multiple modalities that we've mentioned. Many endoscopic therapies are available, and so you have to kind of choose which is going to be best for an individual patient given their factors. Patients with more chronic processes are harder to treat endoscopically. But overall, hopefully I've shown you that endoscopy is a safe and effective option to manage these complications in surgical patients. At the end of the day, we need more long-term data to really get a better understanding of the success rates. And that's it. Thank you.